Okay, our next paper is a rapid-fire paper, Comparison of Surgical Approaches and Prediction of Symptom Improvement for Neurogenic Thoracic Outlet Syndrome from the University of Michigan.
Thank you for the opportunity to present our work. We have no disclosures. So I think the majority of this audience is probably pretty familiar with Neurogenic Thoracic Outlet Syndrome, or NTOS, and we've probably all seen the wide range of symptoms that it can cause, from mild numbness and paresthesias to really disabling pain in the arm, shoulder, and neck. And as we've seen in some of the talks already this morning, patient-reported outcomes have been kind of thought of and applied to this patient population. And there's many that I'm not talking about here, but at least at the University of Michigan, we tend to focus on 3 of them. And so that's the DASH score, which is the disabilities of arm, shoulder, and hand. And that really looks to assess the ability of patients to perform certain upper extremity activities. So I have some examples up there. And then the brief pain inventory, which assesses the severity of pain and its impact on functioning. And this last one's called the PCS, the pain catastrophizing score. And as the name suggests, this is a score to say whether a patient is pain catastrophizing or not. And that's this thought of magnifying the threat of a pain stimulus. So I think we're all well aware of the surgical treatment of neurogenic thoracic outlet syndrome. There's 2 main approaches. I'm sure a lot of people in the audience have significant thoughts about one or the other, but there's the transaxillary approach and the supraclavicular approach. And when we look at studies comparing these two, it's actually quite limited. So most of the large-scale studies are from the 1980s or 1990s, and they're limited to just single approach reports. And when we look at head-to-head comparisons, especially those in the contemporary literature, it's pretty limited. Study out of 2022 with a small cohort of patients, even smaller amount of neurogenic thoracic outlet syndrome patients, did a head-to-head comparison. And then a really nice paper from the Wake Forest group recently, but they only looked at venous TOS cases. And then lastly, there's really a lack of data regarding surgical approach and patient-reported outcomes. So the aim of this study was to assess differences in clinical and patient-reported outcomes after transaxillary and supraclavicular decompression. And we actually hypothesized that there's going to be no difference in outcomes between the 2 approaches. So as a single center review over an 8-year period, we excluded patients who had TOS decompression for venous TOS and or arterial TOS, but we did include those with mixed indications. We collected the variables you can see here, so patient information, patient history, whether they had a scalene plexus block, whether they responded to that block, their preoperative and postoperative questionnaire scores, their surgical approach. And then we broke outcomes into kind of 3 different baskets. So operative outcomes, length of stay, EBL, OR time, clinical outcomes, complication, readmission, reoperation, and then patient-reported outcomes. So the questionnaire scores, and then also if they just subjectively reported symptom resolution or not. So you can see here we had 132 patients in this cohort, 90 of which had the supraclavicular approach, 40 had transaxillary. There's no difference in kind of patient demographics, no difference in whether the patients received a scalene block and or if they responded to that scalene block. And when we look at operative details, there's no difference in estimated blood loss, but the transaxillary approach was associated with decreased operative time and decreased length of stay. The length of stay, that's part of our institutional protocols for each approach, so we were not surprised by that data. When we look at clinical outcomes, no difference in complication or reoperation, a little bit of a signal there for the transaxillary approach for complications, and no difference in subjective symptom improvement. So lastly, when we look at the patient-reported outcomes, if we look at whether they improved in any of the 3 questionnaires, there was no difference. And then if we break this up into improvement of each questionnaire, there's also no difference. So it appears, at least from this data, that the approaches are equivalent, but this led us to really think, well, what if anything is associated with the patients who aren't reporting improvement? So we looked at that briefly. We had 20 patients who reported no improvement. You can see there's a lot of pretty high p-values there, so not a lot of significance. But if you look towards the bottom of this table, you can see there's a little bit of a trend for the preoperative DASH scores being higher in the no improvement group. But most of the statistical significance is with the BPI and whether or not the patient is pain catastrophizing. So lastly, pain catastrophizing is pretty simple. You're either doing it or not. But we wanted to know whether, like what cut point of BPI would predict no symptom improvement, since that's a little less well understood. So we did an ROC curve and a cut point analysis, which found a cut point value of 73.5, pretty good sensitivity and specificity, and that appears to be predicting no symptom improvement. So in conclusion, there's no difference in clinical outcomes or PROs between the 2 approaches. Higher preoperative BPI and PCS scores are associated with no symptom improvement. This BPI of above 73.5 preoperatively may be an important cut point value to consider. And these findings really highlight the importance of including PROs in our patient selection for the surgical management of these patients. I'd like to thank society, my two mentors on this, and happy to take any questions.
Hey, I'm Matt Smith, University of Washington. So many questions. One, your patients who didn't respond, any data on how many of those got scaling blocks, specifically Botox blocks? I find those incredibly helpful in the patients who have kind of multi-shoulder neck symptoms and figuring out who's going to respond. And then also, what's the argument for doing a superclick epicardial approach if the operating time's longer and they stay 5 times longer?
I think I can confidently answer one of those. The other one I may leave up to interpretation. But so at our institution, all patients who get scaling blocks, which is the majority of them, if you remember from the table there, do get the Botox injection with IR, or we have some people with PM&R who do it with interventional pain. And that was not associated with the no symptom improvement group. So I had it buried in that table there, but there was no association with that, which is a little interesting. And then I think in regards to which approach is better, we have the benefit of the trainees here that or at least some of us have learned how to do both approaches. And I think we probably need to further tease out which approach is better for which patient. I think that was the idea and the impetus of this study, and we didn't really get a clear answer. But I think with larger numbers, maybe multi-institutional studies, then we may get a better idea of which patient may be best suited with that approach, knowing the limitations of a little bit longer in-hospital time.
We get one more. The last one is any specific symptoms that guided them to one approach or the other, like specifically like ulnar-based distribution symptoms or T8 symptoms. I find are also more likely to respond to a rib resection because that's the nerve that's being pulled up by the rib.
Yeah, good question. So this was all just, we have the privilege of 2 attendings who trained in 2 different places and thus each prefer 2 different approaches. So all transaxillary approaches were performed by one attending and all supraclavicular were performed by the other. So the decision for each was pretty much attending based.
I wanted to ask about the pain catastrophizing. Is it part of the brief pain index that you give, or is it its own questionnaire that you do separately? And then if patients have, that's whatever the scoring of that is, do you try to get them to see pain psychology or some of your other patients that have some of these issues that are really severe pain and et cetera before you have surgery to see if they can have better outcomes?
That's a really good question. So it is its own questionnaire. So each of those 3 are their own questionnaires. And, we probably have done that in limited amounts, but probably not enough. And I think this data probably suggests that we really should be getting more of a multidisciplinary approach for these patients who are at these high ends of pain, because we're seeing that they're not responding. So I think that's a great idea.
I have questions on the people that didn't improve. Did you look at duration of their symptoms and see if there was a difference between those that improved in symptoms versus those that didn't, like people that didn't improve have symptoms for longer? And also, did any of those have other concurrent arm, shoulder, or hand pathology that could be confounding their lack of improvement?
Yeah, great questions. I anticipated that I'd get that question, and my answer is I'm going to do that for the manuscript because I have not taken a deep look at symptoms preoperatively or time of questionnaire scores, because the questionnaire scores are variable. Some of them are at 1 month, some of them are at 3 months. We don't have great long-term data on these patients because normally after about 3 months, we just send them on their way unless they're not responding. So I think we need to take a deeper look into the different time differences, and we'll certainly do that for the manuscript.
All right, so one comment and one question. Insurance companies are now refusing to pay for the surgery if patients don't have response to either a local anesthetic or a Botox injection. And we know that upwards of 20 or 30% of patients will not have. So having a manuscript that talks about this would be great. The second is we've done 10 of these robotically with excellent results. Has your group looked at doing these robotically?
I'm not aware if we have. I know for the MALS stuff that you presented, we are in the midst of making that a bigger part of the practice, but I'm not aware of any TOS patients being done robotically, but I think that's certainly something we could consider.
They're super easy and they go home same day.
Yeah. Thank you.
Thanks.
Thanks.